Hello and welcome back to Best of the Day from the 55th annual meeting of the American Society of Hematology, meeting this year in New Orleans, where it has been cold and damp, but we're all going back to probably even worse weather, so I guess we'll take what we can get while we're here. So this morning I'm talking to Dr. Jennifer Brown from the Dana-Farber Cancer Institute about chronic lymphocytic leukemia. And now we're going to talk about some of the other novel agents other than the BTK inhibitors. And Jennifer, thanks again for being here. Well, one of the agents that a lot of hope had been put on in the past was oblamersen, this BCL2 oligonucleotide. I sat down with Susan O'Brien several years ago and talked about that, and that drug just never moved very far. But now there's a new drug from AbbVie and Genentech, ABT-199, that is a BCL2 inhibitor. Tell us how this drug differs and tell us about some of the exciting data that's come out at this year's meeting regarding ABT-199.
Mm-hmm. Oblamersen, I think, suffered from the fact of the many problems with oligonucleotide therapeutics in terms of half-life and delivery and tissue penetration. Mm-hmm. So ABT-199 is a small molecule. It's actually a second-generation small molecule, which is the result of long efforts in the Abbott labs to identify specific binding inhibitors to the BH3. They're BH3 mimetics, basically, right, and bind to BCL2 protein and inhibit in that way. It's a hard problem because of the protein-protein interaction surface. The first-generation molecule, ABT-263, had some significant activity in fludarabine refractory CLL, but caused significant thrombocytopenia, which was due to its effect on BCLX long, which reduces platelet survival. Right. This molecule is more entirely specific for BCL2, and thrombocytopenia has not been seen. This molecule is showing fairly remarkable activity in the clinic, even in its phase 1 study, with response rates over 80% and about a 20% complete remission rate. Its potency is such that the main side effect is tumor lysis syndrome, which has actually required some very significant efforts to monitor it to maintain the safety of the drug. And there have been 2 protocol modifications progressively enhancing the monitoring for the tumor lysis. And in this latest rendition, the tumor lysis seems to be controlled, but patients are admitted and monitored very extensively. And so I think the challenge going forward, which I think should be surmountable and is definitely worth the effort, is to figure out how we can safely identify a subgroup of patients who don't need this monitoring or change the dose and schedule to allow for patients to be dosed without this degree of monitoring, yet safely.
So BCL2 is an anti-apoptotic factor. Is it upregulated in all CLL patients, or only patients who have already been treated with BCR signaling pathway inhibitors or cytotoxic drugs? How does it factor into the whole course of chronic lymphocytic leukemia?
BCL2 is essentially universally upregulated in virtually all CLL. And this is interesting because unlike follicular lymphoma, for example, where there's a translocation that upregulates BCL2, there are not genetic activating mutations in CLL that activate BCL2, but it is upregulated essentially universally.
All right. So do you see this agent moving forward in monotherapy, or is it likely to be combined with other agents such as the CD20 antibodies and this sort of thing?
I think this agent could play a big role in eventual efforts to remove chemotherapy. This agent is actually very potent at clearing bone marrow, which has not been as clearly demonstrated with some of the B-cell receptor inhibitors. There's also in vitro synergy between BCL2 inhibition and some of the BCR inhibitors. So I think many people, including me, are quite interested in combining this agent with some of the other novel molecules like the kinase inhibitors, and then also potentially adding an anti-CD20 antibody. And then
So
that may get us to...
So get rid of the alkylators once and for all.
Yes, that may eventually
and the
get us
purine
to
analogs, very good. All right,
MRD
well,
negativity.
let's talk about PI3 kinase. And PI3 kinase is a downstream signaler in this BCR receptor signaling pathway. Along with ibrutinib, a lot of the data has come out with idelalisib. It's just a little bit behind ibrutinib, and idelalisib is a PI3 kinase delta inhibitor. I guess there are like 4 isoforms, but delta is the one that is most important, I think, in CLL. But there's another inhibitor from Infinity, IPI-145, that hits both delta and gamma. What are the advantages to adding PI3 kinase gamma as a target?
Right. So from a CLL perspective, that's still unclear. Gamma is expressed in CLL cells, so there is some potentially enhanced efficacy with gamma, but there's also concern that there could be enhanced toxicity because gamma is predominant in neutrophils and T cells. And I think we don't know yet how that's going to play out in the clinic. The other advantage of gamma, though, is that it broadens the potential applicability of the molecule to even include, for example, T-cell lymphomas.
Right, I see. So then tell us about the idelalisib presentation this morning, the late-breaking abstract. And this was Richard Furman's presentation combining idelalisib and rituximab for previously treated patients.
Mm-hmm. So this is the results of the first registration trial for idelalisib, and this was in relapsed refractory CLL patients. It was a randomized trial comparing idelalisib with rituximab to placebo with rituximab, again in relapsed refractory CLL. And the study was stopped early because of the profound difference in efficacy of the arms, and then made it to the late-breaking abstract podium. Response rates were markedly higher in the idelalisib rituximab arm, and the progression-free survival was also markedly higher. In the control arm, progression-free survival was only about 5.5 months, whereas the curve looks pretty flat in the idelalisib placebo arm, or idelalisib rituximab arm.
So, like adding rituximab to ibrutinib, did rituximab blunt the lymphocytosis that is seen with these agents when they're first started?
Yes, to some extent. It often doesn't completely blunt the lymphocytosis. Chemotherapy may blunt it a little bit more. It varies from patient to patient. The lymphocytosis is not really of clinical significance on some level because it generally doesn't bother the patients at all.
Response criteria.
Exactly.
Yeah. And what about adverse events with idelalisib compared with ibrutinib, and does rituximab change those adverse event profiles?
Mm-hmm. So in this early report of this study, which is only about 5-6 months follow-up, the adverse events are quite balanced in the idelalisib rituximab and the placebo rituximab arm. One adverse event that is somewhat notable with idelalisib that we know about from the earlier studies is colitis, which is seen in a subset of patients and can be a delayed effect. It wasn't seen in this study, but again, the follow-up is 6 months, and sometimes the colitis doesn't emerge till 9, 10, or 12 months. Generally, the colitis can be managed, but it needs to be caught early and then generally treated like inflammatory bowel disease. And in that,
is it an autoimmune process, or?
So the mechanism's not entirely clear. There are various scattered reports of colonoscopy biopsies on different patients that have shown a wide range of inflammatory type infiltrates. We do know that the PI3 kinase delta knockout mouse does get a colitis, and so there's some question that this may be a similar effect.
And how common is that? How commonly is that seen?
So in the relapsed patients, on the order of 6 to 10%. In the upfront studies, it's been higher, more like 20%.
Any prophylactic measures that can be taken?
So prophylaxis hasn't really been investigated and is not generally recommended from the initiation of therapy. But as I said, a high level of suspicion at early sign of diarrhea in the absence of infection, and then treating with potential topical anti-inflammatories as one does for IBD.
Does it resolve with time when the drug is stopped?
It does. It resolves if the drug is stopped, and again with inflammatory bowel disease type therapy. And a reasonable percentage of patients can go back on the drug, either at the same or a lower dose, and not have it recur.
Very good. All right, great. Well, this has been very interesting. I have learned a lot, and I really appreciate your perspectives on all this data. It really helps clear up a lot of my questions, and I hope those of our viewers. So thank you very much for taking time to be with us today. I wish you safe travels home, and I hope you don't get stuck overnight in some airport.
Thank you.
All right,
It's a
thank
pleasure.
you. And thanks to all of you for watching all of these Best of the Day segments from this year's ASH meeting in New Orleans. There is a lot of data on the IMEDX website, so I hope you will watch all of these interviews. Thanks again.